Hello, my name is Dr. Forrest Cummings, and I am a board-certified veterinary small animal internal medicine specialist. Today, we will be talking about diabetes mellitus in cats. Thanks for joining me today for today's talk on diabetes mellitus. Before I get started, I would like to tell you all a little bit about myself. As many of you, I have had an affinity for animals at a very young age. I was always intrigued with biology and how the body worked. My passion for animals carried me to the University of Kentucky to receive a degree in animal science with a minor in biology. I then attended Tuskegee University College of Veterinary Medicine, graduating in 2005 with my doctorate of veterinary medicine. While at Tuskegee, I was introduced to the specialty of internal medicine and immediately fell in love with it. I love the detective work involved in helping to diagnose dogs and cats, ultimately managing their conditions. Following graduation, I completed a rotating internship at the University of Tennessee College of Veterinary Medicine. Rather than applying for an internal medicine residency immediately following my internship, I decided to work as an emergency clinician at a 24-hour specialty hospital while doing relief work as a general practitioner, as I felt this would help me to become a more well-rounded veterinary internist. After 2 years, I started my small animal internal medicine residency, which I completed in 2011, and have been practicing as a veterinary internist ever since. As a veterinary internist, diagnosing and managing challenging endocrine diseases is one of my primary responsibilities, and diabetes mellitus is one of the most common endocrine diseases seen in cats. Before I get into the details of diabetes mellitus, I would like to provide an overview of today's talk, starting with pancreatic anatomy, pathophysiology, clinical signs, lab work abnormalities, potential comorbid conditions, and management options. Okay, let's get started. The pancreas is divided into two portions. The first portion is the exocrine pancreas, which is involved in digestion of lipids, proteins, and carbohydrates. The other portion is known as the endocrine pancreas and contains a nest of cells called the islets of Langerhans. There are 4 primary hormones that are produced in the islets. All of these hormones work in harmony to maintain a fairly tight range of serum glucose. The alpha cells produce glucagon. Glucagon is secreted when the blood glucose drops below the minimum threshold of approximately 70 milligrams per deciliter. Beta cells secrete insulin, whose primary function is to lower blood glucose levels when it approaches the upper threshold of approximately 130 milligrams per deciliter. Delta cells release somatostatin. This hormone inhibits the release of insulin and glucagon. The fourth cell is known as pancreatic polypeptide, formerly known as F cells. The exact mechanism of action of this hormone are not fully understood. However, it is thought to have a role in satiety, as well as a prokinetic effect within the gastrointestinal tract to help aid in digestion. Diabetes occurs when there is a deficiency of insulin production by the beta cells, or if there is prolonged insulin resistance, ultimately resulting in hyperglycemia. Cats tend to have an insulin-independent form of diabetes. This is equivalent to type 2 diabetes seen in humans. With this form of diabetes, there can be insulin resistance or a relative lack of insulin production by the beta cells. In theory, this form of diabetes is reversible and can result in euglycemia or normalization of serum glucose. This may not always occur, and permanent insulin therapy may be required. The common signalment are male cats greater than 10 years of age. Risk factors include pancreatitis, genetics, and glucocorticoid administration. The hallmark clinical signs seen with diabetes include polyuria, polydipsia, polyphagia, and weight loss. A plantigrade stance can also be seen. Other clinical signs include an unkempt hair coat, lethargy, dehydration, anorexia or hyporexia, vomiting, inappropriate urination, and hematuria. If any of these other signs are seen, please start to look for concurrent illnesses. After obtaining a thorough history from the owner and performing the physical exam, additional diagnostic tests should include a CBC, or a complete blood count, biochemical profile, urinalysis, and a urine culture. Additional testing may also be needed to rule out concurrent pancreatitis, hepatobiliary diseases such as cholangiohepatitis and hepatic lipidosis, and endocrine diseases such as hyperthyroidism, acromegaly, and feline Cushing's disease. Potential findings that may be seen on the CBC can include a leukocytosis, which may be the result of an inflammatory or infectious process. Hemoconcentration may also be noted secondary to dehydration. Biochemical findings include hyperglycemia, usually greater than 200 milligrams per deciliter, and elevated liver enzymes. Cats can experience stress hyperglycemia of 300 or sometimes 350 milligrams per deciliter, so it is important to obtain an adequate history to determine if this is secondary to stress response or underlying diabetes. The owner needs to be asked about signs of diabetes. If it cannot be clearly stated by the owner that they are noticing signs of diabetes, measurement of a serum fructosamine can be performed. This test assesses glycemic control over the past 2 to 3 weeks and can aid in the diagnosis of diabetes. Moving to the urinalysis, you can observe a normal to decreased urine-specific gravity. The decreased specific gravity is due to hyperosmotic diuresis secondary to the hyperglycemia. In cats, serum glucoses of greater than 200 milligrams per deciliter will result in glucosuria. Other findings can include ketonuria and bacteriuria. The glucose that is excreted in the urine serves as a perfect energy source for the bacteria naturally located within the urethra to cause an ascending bacterial cystitis. Please remember to culture every newly diagnosed diabetic as well as any chronic diabetic who is difficult to regulate. If your patient has concurrent vomiting and decreased appetite, consider screening for pancreatitis, hepatic lipidosis, and cholangiohepatitis. Measurement of an FPL or a PLI can be a simple way to diagnose pancreatitis. However, abdominal ultrasound may also be needed. When pancreatitis is identified, measurement of serum cobalamin should also be determined. This is because the pancreas exclusively produces intrinsic factor, which is essential for cobalamin absorption within the ileum. An intrinsic factor deficiency will result in hypocobalaminemia, worsening the weight loss, decreased appetite, and the overall health of the patient. Cobalamin supplementation is best administered subcutaneously. Each cat should receive 250 micrograms once weekly for 6 weeks, then monthly thereafter. Treatment may be needed indefinitely. Additionally, if pancreatitis is noted, additional supportive care may be required, such as antiemetics, pain medication, and parenteral fluid support. And abdominal ultrasound can also be helpful in assessing hepatobiliary diseases. Ultimately, ultrasound-guided fine needle aspirates of the liver for cytopathology or liver biopsies may be warranted. At the time of the procedure, bile should also be collected for aerobic and anaerobic culture. Placement of a temporary enteral feeding tube may also be indicated if hepatic lipidosis and prolonged anorexia are present. Lastly, as previously mentioned, screening for concurrent endocrine diseases may be indicated if the diabetes cannot be adequately controlled with insulin therapy alone. This can include screening for hyperthyroidism and feline Cushing's disease, as well as acromegaly. Now that we have performed the diagnostic testing to help determine a definitive diagnosis or diagnoses, let's talk about management options. As discussed, insulin therapy holds the key to proper management of diabetes in veterinary medicine. Unlike dogs, cats have a relative insulin deficiency or insulin resistance, so they may be slightly more responsive to oral hypoglycemic drugs. Oral hypoglycemic drugs are generally not effective in dogs since they work by increasing insulin production from the beta cells. However, in dogs, beta cells are poorly functioning or not functioning at all. Therefore, since the beta cells are presumed to be effective in cats, oral hypoglycemic drugs, such as glipizide, can be an alternative if insulin therapy is not an option. Insulin types include both intermediate and long-acting insulin for the chronic management. Prozinc and glargine are the most common formulations used in cats. However, Vetsolin and Novolin N may also be effective. Please note that both Vetsolin and Prozinc should be administered with U40 syringes only, whereas glargine and Novolin N should be administered with a U100 syringe. Please remember that since cats require such a small volume of insulin, usually 1 to 3 units, accurate dosing may be difficult with U100 syringes. One advantage of the U40 syringe is the ability to have half-unit dosing so patients can receive 1.5 units if needed, as opposed to 1 or 2 units. After starting insulin therapy, a glucose curve should be performed 7 to 10 days either in the hospital or by the owner at home with the use of a glucose monitoring kit. Traditionally, a blood glucose should be performed for a minimum of 12 hours with the reading taken every 2 hours to fully assess the peak and trough of the blood glucose curve between insulin administrations. More recently, continuous glucose monitoring has shown an increase in use due to the lack of serial venipunctures, thus decreasing patient stress and discomfort. A Freestyle Libre 2 continuous blood glucose monitoring kit can be obtained from your local pharmacy and placed on the skin between the shoulder blades by a veterinarian or a trained veterinary staff member. This comes with a monitor that will allow blood glucose to be measured as frequently as every several minutes for up to 14 days. The owner can either manually record the numbers and give them to the veterinarian to review. Alternatively, the data can be accessed electronically through the Freestyle Libre app. Once an adequate insulin dose has been established to maintain a blood glucose between 100 to 300 milligrams per deciliter, a glucose curve should be performed 1 month later and again every 3 to 4 months. A complete CBC, chemistry panel, urinalysis, and urine culture should also be performed every 6 months to assess overall health and to screen for occult urinary tract infections. Finding the ideal insulin type and dose is only one piece of the puzzle in successful management of diabetes mellitus. Within the past several years, more research has been done to assess the effects of fat in the management of diabetes. Both excessive amounts of adipose tissue and hypertriglyceridemia can cause insulin resistance. It is important to try to increase the metabolic rate to help lower the amount of excessive adipose tissue present within the patient. This can be difficult in cats due to their sedentary nature. However, cat toys that encourage movement may be an option. Adipose tissue has been shown to have anti-insulin effects, thus predisposing you to diabetes and making management of diabetes more difficult. Likewise, hyperlipidemia has also been shown to antagonize the effects of insulin. If there is no underlying cause for the hypertriglyceridemia, a combination of prescription low-fat food and medication would be indicated. This can include drugs such as gemfibrozil and fenofibrate. Both gemfibrozil and fenofibrate increase lipoprotein lipase activity and fatty acid oxidation to reduce triglyceride levels. Once initiating therapy, measurement of serum triglycerides should be performed approximately 4 weeks later. Ideally, triglyceride levels should be less than 400 milligrams per deciliter. When deciding on the ideal diet, one that is high in protein and low in carbohydrates is the most effective. One major complication of diabetes is the development of ketoacidosis. These patients can present to the hospital extremely ill, secondary to metabolic acidosis, electrolyte disturbances, and severe dehydration. A characteristic clinical sign is the acetone breath. If the patient is too dehydrated to collect urine to confirm a ketonuria, measurement of serum ketones can be just as effective. The diagnosis of diabetic ketoacidosis should always be considered a potential life-threatening emergency, and the owner should be advised to transfer to a 24-hour emergency clinic for aggressive supportive care. The prognosis for a patient with diabetic ketoacidosis is extremely guarded and will ultimately depend on how quickly medical management is initiated and response to therapy. The mortality rate can range from 30 up to 50%. Ketone bodies are produced secondary to starvation or prolonged hyperglycemia. As a consequence of the body not being able to utilize its primary energy source, it begins to break down fats and proteins through a process called gluconeogenesis. This results in increased amino acid mobilization from extrahepatic tissues and increased free fatty acid oxidation from adipose tissue, ultimately resulting in an accumulation of ketone bodies, namely beta-hydroxybutyrate, acetoacetate, and acetone. At this point, I would like to touch on other endocrinopathies seen with diabetes, such as acromegaly and feline hyperadrenocorticism. These cats tend to require higher doses of insulin therapy that may not necessarily decrease with successful management of the concurrent endocrinopathies. However, it is important to note that the insulin requirement may decrease once the anti-insulin effects are controlled. Families should be instructed to monitor for signs of hypoglycemia after starting therapy. Acromegaly is the result of excessive growth hormone production by the pituitary gland, resulting in insulin resistance. Excessive soft tissue and bony growth, primarily in the head but can affect extremities and the heart, and neurologic deficits. The diagnosis involves advanced imaging of the brain, via CT or MRI and measurement of serum insulin-like growth factor, or IGF, which can be performed at Michigan State University. Treatment can include radiation therapy, hypophysectomy, and high-dose insulin. Other than surgery, there are no real effective treatment options. Unfortunately, pituitary gland removal is not readily performed by most veterinary surgeons. Feline Cushing's disease results in skin fragility that can tear easily with minimal handling. It is diagnosed by performing an ACTH stimulation test or a low-dose dexamethasone suppression test. Treatment options can include medical management with trilostane or mitotane. However, unilateral or bilateral adrenalectomy may be required. Unfortunately, efficacy of treatment is generally poor in all cases. Fortunately, these conditions are not commonly seen. However, they should be considered if the patient is not responding as you would expect and other comorbidities have been ruled out. Unfortunately, the prognosis is extremely guarded when these conditions are found, since they can be extremely difficult to control, resulting in ongoing cost to the owner and a decreased quality of life for the patient. Overall, the prognosis in cats with uncomplicated diabetes mellitus is good, and many can live a normal lifespan as long as complications do not arise and comorbidities do not develop. The prognosis for cats with complicated diabetes can vary depending on the underlying disease processes and their response to therapy. One last and very important point that I would like to stress is the importance of client education when a diagnosis of diabetes is found. Clients need to be fully aware that treatment is lifelong and will require insulin administration. Asking if they are willing to provide the necessary support is going to be essential in successful management. It is also important to ask whether or not the client has a fear of needles and blood, because insulin injections will need to be given twice daily. There is also a financial component that will need to be addressed to pay for medications and necessary diagnostics that are indicated. If these criteria cannot be met, the conversation should be shifted to discuss surrendering the animal to someone that can provide treatment or humane euthanasia. These are not conversations that any of us enjoy having, but they are important nonetheless and are always aimed at making the best decision for the animal. So in summary, we learned about the pancreatic anatomy, the pathophysiology of diabetes, and potential complications of poorly regulated diabetes, including diabetic ketoacidosis. We also discussed diagnostics to help make a definitive diagnosis of diabetes, as well as comorbid conditions such as pancreatitis, cholangiohepatitis, lipidosis, hyperthyroidism, Cushing's disease, and acromegaly. Finally, we discussed successful management of diabetes mellitus as well as client education. So I hope that you enjoyed this talk on diabetes mellitus and it helps you in your practice. If you have any questions or would like to reach out, you can find me on LinkedIn. Thank you so much for watching.